Hello, I'm Dr. Lynne Levitsky. I'm the pediatric endocrinologist on the medical advisory board for the Myhre Syndrome Foundation, and I'm coming to speak with you today about endocrine problems in Myhre syndrome as part of the MSF Summer Seminar Series. I am at Mass General Hospital for Children and Harvard Medical School. I'd like to start with a little caveat, which is that the understanding of Myhre syndrome and its complications is changing rapidly. And not all the information that I'm going to provide you with today, which has been obtained largely from animal and cell models, will end up being directly applicable to people with this condition. Treatments right now for endocrine problems in Myhre syndrome are based upon the common treatments for children with these endocrine problems and aren't really specific treatments for Myhre syndrome, and that's something that's important to keep in mind as well. So what is the problem? Why do we have endocrine problems in Myhre syndrome? So you all, I'm sure, know that it's the gene SMAD4, which is mutated in people who have Myhre syndrome. And these mutations are gain of function mutations, so that the SMAD4 gene works extra hard and doesn't turn itself off. Let's look at SMAD4 and what it does. This is a very clever visual representation by a bunch of mathematical molecular biologists of SMAD4 and its connections to other proteins and other actions. Here is SMAD4 right in the center, the way they drew it. And you can see that there's all sorts of other proteins and other groups of proteins that interact with SMAD4. Some of them are particularly important for endocrine function. For instance, SMAD4 is very important in relationship to a bunch of genes that control ATP activity, which is part of energy metabolism and might relate, for instance, to carbohydrate metabolism and problems with diabetes. SMAD4 is also very important for cell cycle genes, and these are cell cycle genes. So how fast your cells turn over and split into two and grow are controlled by some of these genes. SMAD4 is also important for these genes in sort of a light greenish color here, which are responsible for cell apoptosis. Now, apoptosis is a fancy word for another fancy concept, which is programmed cell death. And what that means is that in order for, say, a kidney to develop, not only do cells have to grow, but some other cells might have to die so that the shape of the kidney can change and develop. And that's called programmed cell death. The death of some cells to allow others to grow so you can change the shape of organs and whole bodies eventually. Those are only a few of the groups of genes that seem to be interacting with SMAD4. There's another group over here which may be important for cancer regulation, for instance, and that's also important, although outside what I'm going to be talking about by and large. So what is SMAD4? The name, if you want to see it all spelled out, is Mothers Against Decapentaplegic Homolog 4, which means really not much at all. A lot of these names for various weird genes were first developed by fruit fly and yeast geneticists, and I think they sit in their labs after 10 o'clock at night drinking coffee and picking up weird names because it keeps themselves entertained. It really says nothing about what this gene does. Important for SMAD4 is that it works as one of the important messengers in the downstream effects of another very important gene, which makes a protein called TGF-beta. And this is important in fibrosis, which is, of course, a problem in people who have Myhre syndrome in that they develop fibrosis very easily. Also in growth and in a lot of very basic cellular processes. So if you have a gain of function mutation, that means that the gene is working harder and may not appropriately stop working. And that seems to be part of the reason why TGF-beta and the whole fibrosis pathway is turned on in these individuals. But SMAD4 also works in other areas as well. So there are endocrine problems in Myhre syndrome, and I was given a list of questions that various members of the Myhre syndrome group have submitted, and they focused on a few different areas. One was whether there is more hypothyroidism in Myhre syndrome and why. Another is about the growth problem in Myhre syndrome. Then problems related to puberty, both early and late. And then the problems of diabetes and metabolic syndrome. I'm going to talk about the first two, and then I'm going to talk about puberty problems and diabetes and metabolic syndrome together, because they really do fit together as examples of insulin resistance, which is an important part of Myhre syndrome. And I'll explain more about this in a bit. So in terms of thyroid problems, is an underactive thyroid, which is what hypothyroidism is, more common in Myhre syndrome? And my answer to this is, I don't think so. In series of people with Myhre syndrome that have been reported, and they're not series of 300, they're series of 30 or 40 or 50, because this is a very rare condition. At least it has been described in a small number of people. It may have gone undiagnosed in many others. Hypothyroidism is not a common finding. But when you think about it, hypothyroidism is a common condition. 1 in 500 children and about 1 in 20 women over the age of 70 are hypothyroid. So it is possible to have Myhre syndrome, which is very rare, and also be hypothyroid, which is not so rare. In addition, if you have a problem with obesity with extra adipose tissue, you can also have an elevated TSH. And that gives you a condition called TSH resistance. And sometimes that can be diagnosed as a thyroid problem, which it may not be. So if you are suffering with a weight problem, you may have TSH resistance. The elevated levels of thyroid stimulating hormone, or TSH, are released by the pituitary gland. And while you have elevated levels of TSH, usually not too high, but high enough to be above normal, you have normal levels of thyroid hormone in the blood. This is called compensated hypothyroidism. And if you have a problem with obesity, it's usually referred to as TSH resistance, and it's usually not treated. If you do treat people like this, it doesn't help them with their weight or staying awake more or anything else. We don't know the mechanism, but it seems to be related somehow to the extra obesity. Growth problems are very real, as you all know, in Myhre syndrome. And one of the questions that was asked is, how should they be treated, particularly because of the risk of diabetes in this condition? So I'm going to back down a little further to take a look at this. So many children with Myhre syndrome are born small. They are said to be IUGR, or intrauterine growth restricted. They're small because their own bodies don't turn over fast enough to grow bigger. And this is not because they're not getting enough food from the placenta or from the mother. It's that there's something actually a problem with them because of their SMAD4 mutation. Many stay small, grow slowly, and then stop growing early because they have rather early puberty, or their bones grow older faster and they fuse their growth plates. And the question for this is why? So let's go back to the SMAD4 gene in that picture I showed you before again. It's important in cell cycle and DNA replication, as well as the natural programmed cell death I talked about. So people who have this mutation, their bodies just aren't turning over fast enough to grow. They're not making enough cells to get bigger, as far as we can tell. And that's a simple explanation, but probably a reason why they stay this size and don't grow as well as others. So is the slow growth and short stature in Myhre syndrome a classic endocrine deficiency disorder? Well, the answer to that is no. Low birth weight and slow growth doesn't have anything to do with the classic hormone deficiency. When we think of hormone deficiencies and growth, we often think of the hormone from the pituitary called growth hormone. Children with this condition have normal levels of growth hormone and also of insulin-like growth factor 1, or IGF-1, which is a marker for growth hormone action. That's really not their problem. They don't look anything like people who have classic growth hormone deficiency. And we now have plenty of pharmaceutical growth hormone around, so people who have classic growth hormone deficiency can be easily treated. What really is going on, as I've described, is that the upregulated SMAD4 mutation interferes with normal cell multiplication and with normal bone formation. So can this slow growth and short stature in Myhre syndrome be treated? Maybe, but not probably very well. So as you know, the old adage, if you only have a hammer, everything looks like a nail, applies to growth disorders. We have a lot of growth hormone around, a super lot of growth hormone. It's given by injection daily, although there are some new preparations which can be given once a week. And if the growth plates are open, even people who make plenty of growth hormone of their own will grow a bit taller if they're given growth hormone. But if there's an underlying problem with cell growth and bone development, they may not grow quite as well as you would expect. So the way we look at this is by looking at bone age x-rays, and I'm sure you probably have shared these with doctors over the years. These are some bone age x-rays, and what we're looking at here, and there's when you stop growing, all these little spaces fill in over here. And those are the growth plates in here. They are actually cartilage. They just don't have calcium in them, so they don't show up in these early pictures. And as the children get older, the spaces get narrower. This is late puberty, and they're almost all closed off over here, so there's very little room to grow, maybe only down at the wrist. There might be a little bit of room to grow. So these are the kinds of pictures we use to predict growth and also to let us know whether there's room for growth for various treatments that we might try. Growth hormone treatment may make you grow a little faster. It may also have some unanticipated risks, which you should know about. It increases insulin resistance, and perhaps that could make things worse in terms of diabetes. People who have diabetes who are given growth hormone because they're often also growth hormone deficient, it's a bear of a time trying to balance their insulin against their growth hormone to get them to grow, but it can be done. In a large European retrospective review that was published not too long ago, it was noted that in people who received growth hormone for many years, there was a slightly increased risk of strokes and other blood vessel problems when these people were young adults, and that the increased risk seemed to correlate with the length that they took growth hormone for. So if you took it for 6 years, you had fewer problems than if you took it for 15 years. So it seemed like there was an association, and that might be so because insulin resistance is associated with some vascular problems that we're aware of. And so maybe this is true, but it's certainly a small association, and it has not stopped most of us from treating children who need it with growth hormone, and certainly the Food and Drug Administration has not prevented us from doing this. So the other thing about growth hormone, though, has always worried us is that the pathways that stimulate growth of cells, the normal growth of cells, so that children grow taller and bigger, also are similar to the pathways that stimulate the growth of malignant cells. A lot of the pathways are the same. Nobody has ever demonstrated that growth hormone can induce a malignancy or stimulate malignancy growth, but nonetheless, we do worry about it. And with a rare condition, could this increase risk? Because we know that there is an increased risk for some malignancies with age and Myhre syndrome. And the answer is we just don't know. No one knows this, but that always hangs there in the air as a little bit of a worry for us. So here's a special question that one of the parents sent in about their child. My child is growing better with growth hormone, but there's another genetic diagnosis, a glucokinase mutation, which gives mild diabetes. Should I be worried? So this is a child who has two very rare genetic conditions. One is Myhre syndrome, which, as you know, is exceedingly rare. And the other is a mild problem with an enzyme called glucokinase, which is the sensor for sugar in the beta cell. And if the glucokinase senses the sugar is, say, creeping up above 80, a little bit of insulin will be released. But if you have this particular mutation, the glucokinase may not sense the sugar creeping up until it maybe gets to 100 or 120. And so insulin is released a little late, giving people mild diabetes, but not with any problems. So we don't have any data to do anything except guess about this. The particular genetic diabetes diagnosis is in general not associated with the long-term complications of diabetes and doesn't require treatment. As a matter of fact, there's not a good way to treat it. But it's possible that a combination of insulin resistance and this unusual genetic diagnosis could make the diabetes worse. So it would be important to try to keep the insulin resistance as little a problem as possible with good treatment, and also check for problems with blood sugar and blood lipids and blood pressure and kidney function as time goes on, in order to make sure when the child is getting and then not getting growth hormone treatment, because this combination is quite unusual and we just don't know. So what is insulin resistance? This is one of those pictures you probably see on late night TV when they advertise how you should get some new exercise treatment. Insulin resistance is correlated with having more fat around your abdomen and having more problems with obesity. It's correlated with lack of exercise, lack of quality sleep, excess carbohydrate consumption, chronic illness and inflammation. If you get a cold, you get more insulin resistant. People who got COVID got more insulin resistant. If you just lie around in bed all day, you get more insulin resistant than if you're jumping and running all over the place. And then, of course, there's tremendous genetic susceptibility. Many of the aspects of genetic susceptibility we do not understand, but in Myhre syndrome, we understand that it seems to correlate with the SMAD4 mutation. So why is this so? So here's a cartoon of insulin resistance with two sets of fat cells, two imaginary adipose organs, as we call them. The one over here are large fat cells that are insulin resistant, and over here are smaller ones that are not. The smaller ones have decreased size of fat cells and decreased number. The larger ones have increased size, adipocyte hypertrophy, and also increased number, zipocyte hyperplasia. And see what's sitting right in the middle of this signaling pathway? TGF-beta and some of the SMADs. So it seems as if these pathways actually stimulate insulin resistance. You get chronic low-grade inflammation from this. The whole thing sets itself up and you can't really control it. So it may be that the children with the Myhre syndrome are fighting a tremendous battle all the time to avoid insulin resistance, but they can fight it, and there are things they can do to reduce the amount of insulin resistance they have. So increased SMAD4, we know if you put SMAD4 into the cells in tissue culture, or you make a bioengineered mouse that has increased SMAD4, they will be insulin resistant and the cells will be insulin resistant. We know that. So this may well be true for people with a hyperactive SMAD4 gene, but you can still fight it. Even if you have the bad genes, you can still fight it. And that fight is on the physical level without medication, basically exercise and careful diet and weight control. So insulin resistance is important in many conditions, some that you wouldn't think of, related to childhood growth and development and Myhre syndrome. One is that it may be important in premature adrenarche, which is a condition of early adrenal puberty, where you have early pubic and axillary hair, usually with an adult body odor, without the rest of puberty. It may be important if you have delayed menstrual cycle. It can be important in polycystic ovary syndrome or PCOS. It can be important in metabolic syndrome, which we will come to, and also in type 2 diabetes. So all of these conditions are more common in Myhre syndrome. Premature adrenarche or premature adrenal development is due in large part to increased action of insulin because of insulin resistance on the adrenal gland. So you get early production of adrenal hormones associated with adrenal puberty, and that gives you the adult body odor and the increased sexual hair growth. It can also lead to an advanced bone age. The adipose cells convert male hormone to female hormone, and it's the female hormone that advances the bone age. There's no treatment to stop premature adrenal puberty. Those steroids are not bad. We all make steroids all the time, but those particular steroids are weak pre-male hormones made by the adrenal that are important for us. And if they get started a little early because the body is a little heavier and there's a little bit of insulin resistance, so be it. But you can block true precocious puberty with medications that suppress pituitary hormones. And this might help with adult height, but we do not know for sure. Certainly wouldn't be harmful because they're just given for the period of time that the child would normally not be in puberty if they start early. So how about that delayed menstrual cycle? Girls with polycystic ovary syndrome can have delayed puberty or just delayed menstrual cycles. PCOS is a funny kind of name because you don't have to have polycystic ovaries, lots of cysts in your ovaries, to have this diagnosis. And about 25% of normal young women have cysts in their ovaries that could be diagnosed this way. So, but it just kept this sort of old name. What it really means is that you have slightly elevated male hormone levels that are free and active, and you have a dysregulated system. Measurements of the various puberty hormones can sort out whether you're dealing with delayed puberty or a variety of PCOS, or this is a problem with other hormones, which might even include prolactin. One person who wrote in said that their child had had a problem with bleeding and problems, and when they finally studied them, they found out they had an elevated prolactin. Now, you can have an elevated prolactin, and that can mimic PCOS. And that can be due to a little growth on the pituitary gland, which can be treated with medication usually. This is not specific to Myhre syndrome, and it's not more common in Myhre syndrome. But you can also get an elevated prolactin if you're scared of having blood tests and you get stuck and you're scared, your prolactin will go up. So I don't exactly know why that person had an elevated prolactin or how it was treated, but nonetheless, it is something that should be measured to figure out what's going on. And there are appropriate treatments for all the reasons for delayed menses, and they should not be different from other people. They're not specific just to Myhre. Polycystic ovary syndrome is at least in part a result of insulin resistance. The ovaries do not function in synchrony with the pituitary hormonal messages. And so you can either have no bleeding or irregular and severe bleeding, which can occur, and you can actually get quite anemic. So it really does need to be treated. You may also have excess body and facial hair, which is called hirsutism, or high levels of male hormones circulating in the blood, which comes from both the ovary and the adrenal. This is part of the whole picture of insulin resistance, although there must be some other special reasons for this as well. And the treatments are the same as for other girls with these conditions. You need to regularize the periods to protect the lining of the uterus and prevent someone from becoming anemic. You need to get your period at least once every 3 months, or you'll end up getting a high risk of uterine cancer when you're in your 30s, for instance. And you can do this either by taking birth control pills, which will also reduce the levels of male hormone in the blood, and also raise up the levels of the binding proteins from male hormone so that it isn't so active. Or you can take the other female hormone, progesterone, once every 3 months or so to just make sure you have one good uterine bleed if you haven't had a period in 3 months. And then for the extra hair, you can use various cosmetic and medication treatments, which we would use for anybody with polycystic ovary syndrome if they had this problem. So of interest, there is kind of male equivalent of polycystic ovary syndrome, which is being looked at now. And I've seen it in 1 or 2 boys, I think, with Myhre syndrome. And these are boys who seem to have more body hair than other family members, and they may develop early male pattern baldness. Some of this is stress, but it also may be a pattern like PCOS of responding to the rather higher levels or chronic levels of male hormone and other hormones related to the syndrome. And the treatments are the same as for other people with these conditions. In boys, you use treatment with topical medications to reduce the loss of hair and cosmetic approaches as necessary. A lot of this may be related to high stress levels in kids who see the world a little differently from others. So what is metabolic syndrome? To make the diagnosis, you have to have 3 of this series of things: a large waist circumference, that sort of apple-shaped person, and even little kids can have it; a high triglyceride level, which is one of the lipid levels in the blood, probably related to carbohydrate intake and insulin resistance; and a low level of HDL, the high density lipoprotein, which is the good cholesterol. You have to have increased blood pressure for your age, and you can have an elevated fasting blood sugar or glucose intolerance. And all you need is 3 of those, and you're diagnosed with metabolic syndrome. So, depending upon its severity, the treatment is similar for metabolic syndrome and type 2 diabetes. The first line of treatment is weight loss, diet, and exercise, and those treatments are available for all children, although they sure are hard to implement. Medication like metformin, which lowers insulin resistance and is commonly used in type 2 diabetes, can sometimes be very helpful. And then there are some new medications, 1 or 2 of which have become available for young people that help with insulin release and also weight loss, and they're very effective. There are some other medications which are basically being used in type 2 diabetes and not in metabolic syndrome yet, which decrease the need for your own body to release insulin because they get rid of sugar that would be sent back to the body by sending it out into the urine, and decrease the amount of sugar picked up by the gut as well. Perhaps to have type 2 diabetes rather than metabolic syndrome, you need to have a combination of insulin resistance and failure of the pancreatic islet beta cells to release enough insulin. SMAD4 may be important in insulin release. There are some studies suggesting this, but the mechanism is really quite unclear. So the first line of treatment in early type 2 diabetes is weight loss, diet, and exercise. The next would be medications like metformin to lower insulin resistance. And then the newer medications I just talked about, all of which are very effective. The ones that are available for children are marked with a star. And of course, insulin has always been used for type 2 diabetes, but it probably is not the best drug compared with these other drugs because it seems to not decrease complications of diabetes as much as we would like it, as much as these other drugs do. So here are some specific questions. Should there be screening for diabetes, and should people with Myhre worry about their blood sugars? What if there's an increased family risk for diabetes? All people with Myhre should be screened from pre-adolescence on at least yearly for diabetes, about age 10, and for metabolic syndrome. Control of weight with a healthy diet and exercise will help to prevent severe metabolic syndrome, and also will keep a person with Myhre feeling better. Motion is lotion, as they say. So this question was asked by someone who had a child with Myhre, and the mother had type 1 diabetes, which is an autoimmune condition. If a child is born to a mother with type 1 diabetes, that child has about a 4% risk of getting type 1 diabetes, and to a father who has type 1, about a 6% risk. We don't know if the risk changes if the child also has Myhre syndrome, but the risk of a combination of type 1, which is autoimmune, and type 2 diabetes because of weight gain and inactivity is possible. Myhre syndrome people, to my knowledge, don't have an increased risk of autoimmunity, so that shouldn't be a problem. Should early puberty be stopped? Depending upon the kind of early puberty, attempts to stop it or slow it down may well improve adults' height and shouldn't harm the person being treated with medications to block puberty until a normal age of puberty, as I mentioned. But there are some other future treatments which might be pointed, and a couple of them are available right now. Okay, so one is the use of aromatase inhibitors. An aromatase inhibitor is a drug which blocks the conversion of male hormone to female hormone, and they were developed to help women with breast cancer so they wouldn't get breast cancer back again, because some breast cancers are very sensitive to female hormone, and the thought was if you could block the female hormone, then the cancer wouldn't come back, and this has been shown to be true. But they're now available to treat anyone in whom you don't want female hormone levels to go up, because female hormone is what advances the bone age, as I pointed out. And there are studies in boys who are destined to be somewhat shorter than they would like to be, where they were given one of these aromatase inhibitors. The 2 drugs that are available in the United States are anastrozole and letrozole, for example. And if they took these, which is their pills, once a day for about 2 or 3 years, they actually ended up taller than predicted because their bones didn't get older. So the use of aromatase inhibitors in Myhre syndrome is anecdotal. I found one patient who'd been treated with growth hormone and an aromatase inhibitor who looked like he was growing taller. There may be others who've given this combination as well. What we don't know is whether the only reason for the advanced bone age in Myhre syndrome is because of the androgen and estrogen, or whether there are other things going on at the level of the growth plate, which there could be. But certainly this is not a very harmful drug. There are very few side effects of using something like an anastrozole. And if the child will take the pill, it might be something that would be helpful as the child is getting older, and you don't want them to stop growing when they're only 13 or so if they're going to be quite short. This is a drug which is available for treating achondroplasia, CNP, C-natriuretic peptide analog. And this probably was named a little bit wrong, but what has been discovered is that CNP is important in blocking growth plate fusion. It kind of blocks the chemical processes which lead to growth plate fusion, and it's been successfully approved for use in achondroplasia. There are some theoretical reasons to believe it could delay growth plate closing in Myhre syndrome as well, but the studies would have to be very careful because side effects could be different in these children. So that's a possibility that one could use this. Then there's another drug, which I believe there are several ongoing clinical trials of, and that's losartan. Losartan is an antihypertensive drug which has been used in adults for a long time. One of its side effects is to block TGF-beta mediated actions, and those are the actions which lead to fibrosis. So the ongoing trials are looking to see if the agent will decrease fibrosis in Myhre syndrome, and there's one suggestion from a study of 4 patients who were adults that it actually did decrease fibrosis in terms of joint mobility, et cetera. Would this kind of drug also have an effect on insulin resistance if the fibrosis is also part of the insulin resistance picture, which it may well be? We don't know, but it's something that should be studied in the future. So those might be potential treatments for the future. We just don't know. Now, so you may have other questions, and I'm very happy to answer them. You can reach out to me by email. My email is lynne.levitsky@mgh.harvard.edu, and I will answer within a day or two as best I can. The issue of Myhre syndrome and endocrine problems is very poorly studied, and a lot of the things we do, we base upon treatments for other children who don't have Myhre syndrome. So we're all learning as we go along, and I feel free to try to teach me as well when you respond with your emails. Thank you very much for listening.